First day, residency, Arizona, day 1. Hey!
Hi!
Okay, so we're gonna practice now. And tomorrow's check-off. We're not coming back here.
No, we're not.
Okay?
We all of us have to make it.
We're praying.
We already made
Yes.
it because it is not by our power.
Yes,
Yeah.
we're praying and we're gonna be okay in
Yes.
Jesus' name.
Amen.
The knees is going to be a similar idea. Probably the easiest way that I like to describe this is you got to start with kind of visualizing the joint itself. So you have the joint and you have the surrounding structures that basically will support it. So you have the ligaments either anterior posteriorly or on either side laterally and medially, right? It's like a box. So you have the knee and you have front and back, side to side. Those structures really are what support the knee and allow us to, move and all that without just falling apart. So that's what we're essentially testing. So that's the idea. You have to know kind of why am I doing this, and it's not just about moving people around and to have some pain. So I'm starting to kind of identify maybe a particular structure problem. Is it a medial meniscus? Is it lateral ligament? Anterior, what is it that might be the problem, gives you an idea. So knowing that, going into these tests, I think would help. So let's do anterior posterior first. So you can do this in a chair. There's many ways to do this. If you see videos on this, you'll see different positions of the patient. That's going to depend on the patient themselves and kind of your environment and your comfort level. So this could have easily have been like a table, exam table. Patient lays down on their back. That's totally fine. Really, there's multiple ways to do it. So, but if it's like, let's say maybe a frail little lady or something, maybe they can't get up on a table too easily, you can do a lot of these things in the chair. And I'll point out some highlights to keep in mind. So, and I'll rotate around if you guys can't see, but if we're gonna do the knee stuff, one key point to remember is isolation. So you want to make sure you isolate whatever structure you're kind of aiming for. Because if we're just moving things around, you may not actually be testing the knee itself. So if I kind of attempt to do this and I'm just kind of going like this, what am I testing? We don't know. Yeah. Chair's kind of moving. You might end up testing the hip, and not the knee. So we have to isolate the joint itself. So if we're doing it in the chair, they can you can kind of support them on your body somehow. So it might be like maybe on my thigh here. So bend, please. Yeah, like this. So if this was a table, they could again have their foot kind of flat on the table, and then maybe you can sit on top of it or just make sure that it's supported so it doesn't move. So that's part of the isolation. So from there, you want to grab onto the joint itself. So we're going to be doing the drawer test here. So getting a good grip is going to be helpful. So what we're doing is we're trying to move the tibia, okay, the proximal tibial head there. So I'm grabbing on, and I'm going to push kind of in this direction towards the patient posteriorly. That's the posterior drawer. So I'm just applying pressure. Now you don't have to do too much. We're looking for any sort of laxity there. So normally there shouldn't be much movement. That's the whole point of the structures, is that it keeps everything in place. You don't want the tibial head moving around everywhere. So if there was some abnormal motion where you feel the tibial head kind of going past a certain point, it really shouldn't be moving much at all, and you'll be able to tell the difference if you ever see this yourself. But that's the idea. So it should be pretty stable, really shouldn't be moving much. They might have pain, but again, just having pain is not a positive test. Does that make sense?
Yeah.
So similarly, the anterior drawer, you're trying to shift the tibial head anteriorly. So again, supporting and isolating the joint is important. So pushing is posterior, pulling is anterior, like a drawer, if you're opening and closing a drawer. Okay? That's it for drawer test.
Can you repeat that?
Yeah. Yep. Let's turn. Is this okay if we go this way?
I'm good with that.
Yeah. Those words refer to the force. There's just a valgus force and a varus force. So valgus, we're going to be evaluating the medial ligament. So again, they could be laying down, but if I just kind of extend here, you want to support the joint itself, again, in efforts to isolate here. If I start to apply pressure outwards here on the distal portion, so like maybe on their ankle here, that's going to apply pressure immediately. So let's turn a little bit this way too. Supporting the joint, I'm applying some pressure this way, outwards. So again, visualize that tibial head starting to press inwards or medially. A little bit here. Makes a little more sense when you do it. So I'm pressing outwards, and the tibial head will be kind of pushing in that direction. So I'm testing the medial ligament. Likewise, you would just do the opposite for the lateral. So if I kind of pull inwards here, support the joint, I'm applying pressure with the lateral ligament. So it's the same thing, just reversed. One more time. So if I pull inward here towards me, I'm applying pressure on that lateral wall. And likewise, if I switch positions, same thing towards me, but at this time I'm applying pressure that way. So that's the big drive, what needs to happen in order to assess the particular structures. So you have the meniscal structures that kind of go around like a ring too, so other than those four wall structures that we already evaluated. So what we're trying to do is we're doing a twisting motion, so we're aiming for a particular part of the knee joint, but we're also doing an extension at the same time to try to pinch that structure. So if we're kind of like, let's say we're trying to assess one corner of the joint, we're twisting so that we aim for that maybe upper or the posterior corner, for example. We do an extension of the joint, and that's what's actually going to pinch that tibial head, against that structure. So a little hard to describe with words. It's a little easier when you do it yourself. I'm just trying to describe a little bit of kind of what happens, why we're doing a figure eight motion. But it's not just the figure eight motion. So this is the biggest confusion. Students just start, with this twisting motion, and that's not it. So it's the figure eight kind of motion, but you're doing an extension. So try to relax. So the hardest part is getting the patient to relax and get a good position. Support the joint with your one hand. I'm going to twist, so this is the kind of the figure eight motion. But while I do that, towards the end, I'm going to start to extend the joint, extension. And if you visualize that pinching action that is happening because the tibial head is going to go against that structure now. So again, like a twist and then an extension right at the end. So twisting and then extension. Extension. So that's where the figure eight comes in, but it's not just the figure eight, it's the figure eight and then the extension. So again, you can do it different ways. The patient can be lying down. That might be easier sometimes than a chair, but at least in the chair you can get an idea, with some of these. Support the joint. I can't say that enough, and that's going to help with the isolation too. So one hand you're supporting, the other hand you're manipulating the distal lower extremity.
I have a question.
Yeah. The videos on this or descriptions, students tend to struggle with this whole figure eight concept. Probably the easiest way to figure this out is again to kind of visualize the structures. So the figure eight motion is just trying to describe what needs to happen in order to assess the particular structures. So you have the meniscal structures that kind of go around like a ring too, other than those four wall structures that we already evaluated. So what we're trying to do is we're doing a twisting motion, so we're aiming for a particular part of the knee joint, but we're also doing an extension at the same time to try to pinch that structure. So if we're kind of like let's say we're trying to assess the one corner of the joint. We're twisting so that we aim for that maybe upper or the posterior corner, for example. We do an extension of the joint, and that's what's actually going to pinch that tibial head against that structure. A little hard to describe with words. It's a little easier when you do it yourself. I'm just trying to describe a little bit of kind of what happened, why we're doing a figure eight motion. And it's not just the figure eight motion. So this is the biggest confusion. Students just start, with this twisting motion, and that's not it. So it's the figure eight kind of motion, but you're doing an extension. So try to relax. So the hardest part is getting the patient to relax and get a good position. Support the joint with your one hand. I'm going to twist, so this is the kind of the figure eight motion. But while I do that, towards the end, I'm going to start to extend the joint, extension. And if you, again, you visualize that pinching action that is happening because the tibial head is going to go against that structure now. So again, like a twist and then an extension right at the end. So twisting and then extension. Extension. So that's where the figure eight comes in, but it's not just the figure eight, it's the figure eight and then the extension. So again, you can do it different ways. The patient can be lying down. That might be easier sometimes than a chair, but at least in the chair you can get an idea, with some of these. Support the joint. I can't say that enough, and that's going to help with the isolation too. So one hand you're supporting, the other hand you're manipulating the distal lower extremity.
I have a question.
Yeah.
The twist, are you going counterclockwise when you're going lateral? So I just saw you go like one way and then I saw you go the other way.
Yes.
Okay, just want to confirm.
Yeah.
That we're not always going to the same direction. It'll be
Yeah, so
clockwise
again,
and counterclockwise.
Right, yeah,
Okay.
so it depends on what you're trying to assess.
Okay,
Mhm.
great.
So you can do it different ways, but you have to kind of combine those two motions in order to get it to happen. And the other thing that I believe is on your sheets is the allotment test. That's just a pretty basic thing, looking for swelling of the knee. No particular special technique to that. You can just assess the knee by allotment or kind of milking it. You're trying to assess if there's really like a fluid collection going on there. It's pretty basic. Any questions? Anybody need me to anything else?
When you were doing the other exams for the knee differential diagnosis, you're looking at like, do they have an ACL or an MCL tear? Is that what you're looking for?
That's what it's going to help us to assess that. So again, these aren't perfect, but when you suspect a particular structure, it could be maybe the location of their pain or a certain movement that might be related to that structure. You can do these tests and it may give you an idea. Again, most of it is going to be based off of instability, not just pain. So you could do any of these things no matter what. They can have pain, doesn't necessarily mean they have an injury to the structure, or I really want to make that clear. So that's hard sometimes for students to get down, is that we're not just looking at pain. You can have pain no matter what, especially after injury. But if there's an actual structural issue, that's what we're assessing. And that being said, that's a more serious thing. So another point is not just to say, oh, you have this and that. We're trying to assess, is there really instability of the joint? So if there is, that could be problematic. So it may change our treatment plan. Maybe we refer them to orthopedics a little sooner, or get them a brace, at least temporarily, if it's really going to be unstable.
Contraindications, the first thing, you don't want to do this, you think they got a tibial plateau fracture. Is there any other contraindications or anything where you don't want to do these exams?
Yeah, maybe not absolute, but certainly if there's a history of trauma or something, and this is the reason to get a good history first. If they had some significant injury or fall or something, maybe you want to get an x-ray first, at least to establish, and maybe you see them in follow-up and you can try to fine-tune a little bit. Sometimes if there's just an extreme pain, don't push patients to do these things if they're really struggling. You can get a lot of inflammation, and it can be very difficult for them. I don't think you're going to get much value out of doing the test if that's the case. Yeah, you're welcome. Anybody else? Good? Clear as mud? Yeah, so again, I don't expect you to be masters at this. That's kind of the point of the weekend, is you kind of get an idea. This hopefully helped to clarify things a little bit as we break up into smaller groups over the weekend, or if you have questions, just grab us. Even when you're practicing today, if you have a few minutes and you wanted to go over it again, we can. All right, I think that's it for us for the morning. Whatever time is left, start practicing, and then lunch will be served close to noon, so you guys can break for that.